Thanks a lot, Zoe. Thank you for the introduction and thank you for the opportunity to speak here tonight. As mentioned, I'm speaking on managing liver disease in general practice, and thanks to the audience as well for tuning in on a Wednesday night. Here are my disclosures, and these are the learning objectives for tonight. You'll see this slide again at the end of this presentation before we move on. I thought I'd start off by talking about the fatal burden of liver disease in Australia. The AIHW released a burden of disease study report at the end of last year, which is publicly available, and only this year they've allowed you to go into the website and manipulate the data a little bit. And looking at the fatal burden of disease as measured by the metric of years of life lost, chronic liver diseases rank 10th on that list and make up 2.4% as a proportion. Slightly higher in males as expected, 2.8%, and 12th in females. However, when we take into account liver cancer as well, and liver cancer here includes all forms of primary liver cancer, so hepatocellular carcinoma makes up the lion's share of this, over 90%, and cholangiocarcinoma as well as the rarer tumours. That still has a significant burden at 17 in line and 1.5% again with the male predominance. However, what I'd like to hammer home is when you consider both of these factors together, the fatal burden of liver disease and liver cancer, the overall fatal burden is actually 6th overall and 4th in males. And if I just take your, sorry, over here, I just have to move the control panel. What's ahead of that? So if it's 6th overall, this is the top 6 causes of death in our population as measured by years of life lost and the proportions. So it would actually rank higher than bowel cancer at 3.9% as a proportion if we take into account the population we see in the liver clinic. Similarly, in males, it would rank just below lung cancer and above stroke, bowel cancer and COPD. So I think this is a real wake-up call to how significant liver disease is and its high death rate and high fatal burden. I guess another way to look at it is to hammer down on the populations, and this again is in the same report where the top causes are stratified here by ranking here on the left and then by age groups. And if we play bingo with this card, the colours here just to group different diseases. So, for example, cancer's in yellow. We can see that liver disease is the 4th most common cause of death, even in the 25 to 44 age group, and certainly hits a peak at 54 to 64. And you can see that liver cancer also comes into play as a top 10 cause of death according to years of life lost. As far as what's here in the boxes themselves, 13.8 is the years of life lost per 1,000 of population, and 5.8% again is a proportion of the total years of life lost. In females, although less of a priority, that there's still, as in liver diseases rank still in the top 10 across those age groups, but there is a higher age group ranking in the 25 to 44 group there. And so if you look just again at liver disease alone as coded by ICD codes in the same study, from 2003 to 2015, there's been a 35.5 increase in years lived with a disability, 10.7% increase in disability adjusted life years, and a 10.4% increase in years of life lost. In terms of HCC, and here this is a different metric, we're using the standardized mortality rate, that has increased over time progressively from 1982 upwards. This blue line is for the total population, red is in males, and green is for females. So this is certainly a concerning factor and sort of highlights really that early diagnosis and recognition of those at risk are really essential to proving outcomes for patients with liver disease. To illustrate this fact further, this is from a review article in Nature Reviews Gastro and Hepatology, more about portal hypertension, but the graphic here sort of illustrates the point that if you intervene early, and in this case, viral eradication, alcohol withdrawal, weight loss for fatty liver disease, you can see that the downstream effects are somewhat attenuated. You have lots of opportunities to avoid these downstream effects having an impact on survival, and in fact you'll improve survival by intervening early. If you let the disease progress, so in liver disease, once the onset of portal hypertension, ensues, and you have other things like bacterial translocation, apologies there, you can see that there's less opportunity to intervene and less of a way of improving survival. And finally, in the decompensated stage or late stage of disease, you're essentially having to act at multiple targets to achieve less of an improvement in survival. So really the key goes back to preventative health or early diagnosis and early intervention. And this isn't something new in liver disease, these concepts. This is an excellent review that was published 8 years ago now, and it shows about some of the things that are still emerging, but really this paradigm shift that we should be managing patients with cirrhosis or advanced liver disease much more proactively. So just to recap on terminology, so cirrhosis is really a 200-year-old term that hasn't been updated. It describes the distortion of liver architecture due to extensive fibrosis and nodule formation, and really it is at heart a histopathological diagnosis, although we use the term now to talk about the clinical spectrum of disease, and we can diagnose cirrhosis on imaging or from clinical stigmata, or have an idea on non-invasive testing. But really the hallmark of cirrhosis is the histological definition there. When we talk about disease states, and we talk about compensated, which is really the stable phase of the disease with minimal clinical manifestations, portal hypertension may exist at this stage, but it doesn't have any overt clinical signs outside of being detectable on radiological investigations or perhaps non-bleeding varices at endoscopy. Decompensation is defined clinically, and that's by ascites, hepatic encephalopathy, variceal bleeding, or new non-obstructive jaundice. And this represents a very unstable phase of the disease with very high short-term mortality, which I'll talk about later. You'll also hear the term liver failure being bandied about, and again, this is a bit more of a nebulous term, but really it refers to impairment of synthetic or metabolic functions of the liver. That can be acute, so fulminant or acute liver failure, which is a distinct syndrome. Chronic liver failure, which it really is decompensated disease or decompensated cirrhosis, or the new entity of acute on chronic liver failure, which describes essentially organ failures in the setting of cirrhosis. There's recently been a push to use this term, advanced chronic liver disease, and this is really something that's been driven by the non-invasive fibrosis testing era, and I'll describe this in a bit more detail further on. And really this term is to identify those at higher risk of clinical decompensation, developing hepatocellular carcinoma, and ultimately death. The reason why this is a departure from cirrhosis is because we rarely use histology anymore to diagnose this higher risk group. Secondly, some of the complications we associate with cirrhosis can actually happen before you have histological cirrhosis. So the prime example is in fatty liver disease, you can develop HCC with F3 fibrosis, or in a lot of cholestatic diseases, you might develop portal hypertension before developing histological cirrhosis. I guess the other thing to mention, and we're talking about compensated and decompensated disease, this is kind of the paradigm that we've been using to stratify disease for the last 15 years. This column here refers to 1 year mortality, and you can see that in compensated disease with no varices, no ascites, the risk of death in a year is 1%. Even still in stage 2, where you might have varices but no ascites, the risk of death is 3.4%. There's been a fifth stage proposed with renal failure and infection, but really the initial jump is from compensated to decompensated. You can see 3.4% to 20% in 1 year, and then subsequently another jump from 20% to 57% at stage 4. The other thing to remember is time in these disease states. So compensated, really people spend years in the compensated state, and the median survival for compensated cirrhosis of any cause is around 12 years, compared to decompensated, which is months. The median survival is somewhere between 1 and 2 years. Now, of course, one thing that this model doesn't do is have the arrows facing the other way. So some people, obviously after a decompensation event, people may recompensate. And that's something that is its focus for research in how we can look at decompensating events in a cumulative fashion. So what is happening in Australia? This is another population modelling report that was commissioned by the Australian Liver Association. Deloitte ran this burden of disease study. And essentially, it was looking at data in 2012 before the DAA era in hepatitis C, and the estimated burden of liver disease, so NAFLD here, was making up 5.5 million cases of liver disease, and the projections to 2030 was that number would increase up to 7 million, with a total burden of liver disease affecting 8 million Australians. You can see the other big risk groups are viral hepatitis, primary liver cancer. Now, there's a lot of issues with the way this was reported back then, because this was just using the cancer registries, which require histology, and we require, we make the diagnosis these days, and certainly for the last 10 years of HCC on imaging criteria in cirrhosis over 90% of the time. So this didn't capture a lot of the primary liver cancer cases, and same with the alcohol-related liver disease was underreported. However, the overall economic burden was calculated, and it was still quite an impressive figure. So liver diseases here in the right-hand side column, you can see has a higher cost in terms of burden of disease than type 2 diabetes, and these are chronic kidney diseases related to type 2 diabetes. So those two combined, cardiovascular disease clearly has a higher burden of disease. The other thing I thought I'd highlight before we progress is the renaming of non-alcoholic fatty liver disease to metabolic dysfunction associated fatty liver disease, or MAFLD. This is a very new change in the nomenclature that's been driven by an international consensus panel that's been led by Jacob George and Mohammed Eslam at Westmead Hospital. And you may see this term being bandied about, and that's why I thought it would be relevant to mention it tonight. Essentially, the reason to move away from, again, an outdated term is to remove the association of alcohol, because often it will coexist without being a major cofactor, or it may be a major cofactor in certain people, but really the pathophysiology may or may not be related, and hence MAFLD removes that. It also removes the concept that there's a difference between NASH and fatty liver disease. And hopefully with this definition, and again, we'll talk through the algorithm in a minute, it will create better understandings of the pathophysiology. So what we'll end up seeing is subtypes of MAFLD based on either biomarkers or metabolic profiles. So essentially, to make the diagnosis, you have to start off with steatosis, either by ultrasound, or there's not really a good blood biomarker of hepatic steatosis. But certainly on histology, you can make that diagnosis. And in the patient with steatosis who's overweight, BMI over 25 for Caucasians, they've automatically got MAFLD. For those with type 2 diabetes, they also automatically get MAFLD if they've got steatosis on an ultrasound. And those with who are lean or have a normal weight, normal BMI, need 2 of the following metabolic risk abnormalities, which are listed here. Nothing there is terribly surprising. Just talking about chronic liver diseases in general, I guess the things to be aware about and to think about liver diseases when your patient in the clinic has significant alcohol intake outside the NHMRC guidelines. Certainly, as we mentioned on the previous slide, obesity, type 2 diabetes, any other metabolic risk factors, viral hepatitis risk factors, autoimmune diseases, particularly IBD with the link with primary sclerosing cholangitis, hemochromatosis, family history of cirrhosis or liver cancer, and ethnicity, which should trigger off screening. In Australia, typically means hepatitis B in people who've migrated from endemic areas, but also that could have implications for hepatitis C as well. I won't dwell on this, but as we know from history, the majority are asymptomatic, but there might be some history of fatigue. Some people may complain of itch, and that's often can be a sign of cholestatic liver disease, like primary biliary cholangitis. They might have weight gain for fluid retention or loss in the setting of hepatocellular carcinoma. They may complain that they or a relative has noticed they've gone yellow, abdominal distension from ascites, and confusion referring to an encephalopathy. And on examination, they may or may not have signs of chronic liver disease, and I won't go through those in detail. A very relevant reference is this guideline put out by the British Society of Gastroenterology, and I've provided another link towards the end. And this gives a nice overview. It is a bit of a cumbersome document at 30 pages on how to manage abnormal liver blood tests. And I'd like to just draw your attention to the first figure in that document. And it is a bit of an octopus. There's a lot going on in this algorithm, but if you break it down systematically, it is kind of what already happens in the majority of practice, but it's worthwhile going through anyway. So as mentioned, if you have a history of risk factors, as we've just talked about, with some clinical pattern recognition, you'll shunt down each of these algorithms. So if they've got significant alcohol risk, they do provide a separate alcohol risk algorithm for those with alcohol-related liver disease. But really, in either of the two firearms, it's if they have a hepatic picture, you can, I guess in this setting, they assume you haven't done the blood test yet. I don't know how you find the ALT and AST without doing that, but anyway. So you've done your liver biochemistry, and they suggest you order an ultrasound and then a liver etiology screen. And then basically the differential is, do they have fatty liver disease and risk factors for that, or is their ultrasound normal? And if so, then if they still have a hepatic picture, then refer for further evaluation to a liver clinic. If the ultrasound's abnormal here, or they've got any positive features on the liver screen, they still should be referred. And we'll talk about the fatty liver algorithm if they've got NAFLD risk factors. If they've got a cholestatic picture, a very similar screening. And I think in the Australian population, while we're trying to push towards Hep C eradication, we certainly should be screening for viral hepatitis on both sides of this algorithm. And then obtain an ultrasound. Again, if they have persistently abnormal cholestatic enzymes, then they should be referred. Clearly, if they have synthetic failure or suspected malignancy, then they should be urgently referred, even to the emergency department. Again, we'll talk about that through later in the talk. And finally, if they have an isolated raised bilirubin, what to do with that. And clearly, coming down to the bottom of the algorithm, considering Gilbert syndrome is perhaps one of the major things there. So the other thing to mention, and the thing that's really changed hepatology, is these non-invasive tests of liver fibrosis. And they've allowed for earlier detection of liver fibrosis and really have changed what we do at the point of care. They've showed us how to improve risk stratification and prognostication, and they've given the ability to perform multiple assessments across the disease course. And that's really changed the paradigm, both in the pathophysiological understanding of chronic liver diseases, but also in the management. As far as non-invasive tests, we talk about elastography, which is the measurement of liver stiffness, and that can be done by different ultrasound modalities, which I'll talk about, and MRI, which is not really accessible here in Sydney. It's has associated costs and is certainly hard to come by. The other major component is serum markers, and that really comprises of direct markers, so markers that are actually involved in the fibrogenic process, so that things like hyaluronic acid or combinations of and pro-collagen derivatives, and they're often incorporated into tests that are proprietary or paid for, like HepaScore or ELF, which is the Enhanced Liver Fibrosis panel. And then you have indirect markers, which are parameters that have been correlated with fibrosis but aren't involved in the fibrogenic process. So things like transaminases, platelet count, or age, for example. And again, these have been combined in algorithms. All non-invasive tests are calibrated against histological staging. And just to remind you, there's multiple scoring systems that are used, but essentially when we talk about non-invasive tests, we're grading from F1 to F4. F1 being minimal or no fibrosis, and this is meant to be your central vein, and these are the portal tracts. You see there's not really any fibrosis, maybe something here on histology saying some subtle portal fibrosis. F2 is where you start getting these septae forming out from the portal tracts. Then you have septal fibrosis, so these portal linkages here, and the start of some bridging fibrosis to the central vein here. And so you can start making out a nodule there. And then you go to F4, which is full-blown cirrhosis with discrete nodules. So to put this into context, if you've got a patient who's got early to advanced liver fibrosis and then they develop cirrhosis without clinical manifestations, they develop clinical manifestations and ultimately liver failure. We've traditionally only had liver biopsy, which is useful up to the point of cirrhosis, but doesn't give you any more prognostic information afterwards. It doesn't tell you if the patient's decompensated or will they decompensate. It just tells you if they're cirrhotic or not, or those stages before that. So if they've got advanced fibrosis or F3. Beyond that, we have the hepatic venous pressure gradient measurement, which is basically an angiographic procedure where a catheter is dropped into the jugular vein and the pressures across the liver are measured. And that has excellent prognostic value once cirrhosis is established. So this is all that existed prior to about 10 years ago, or 10 to 15 years ago. And what we've seen now is this explosion of non-invasive tests that now can give more prognostic information beyond just a diagnosis of cirrhosis. So particularly liver stiffness measurement and these indirect and direct serum markers of fibrosis. And these are the most validated of the non-invasive tests, and there's other ones coming like spleen stiffness and other biomarkers that are correlated with outcomes. And really the whole point is, again, to go back to that group of advanced chronic liver disease, which might begin at advanced fibrosis or the very tip end of advanced fibrosis, and the risk of decompensation, HCC and death increases as they progress along this spectrum. One thing to say is that as far as regression of fibrosis, and we know now that early cirrhosis can regress, so with prolonged viral hepatitis treatment or bariatric surgery in the case of a very early stage cirrhosis, we might find that it does regress. However, there is no validated non-invasive markers for regression of fibrosis or portal hypertension. So if people had cirrhosis before treatment, they have cirrhosis after treatment unless you've got a biopsy saying otherwise. So they still need HCC screening and ongoing follow-up. Just to hammer home that point about the explosion of non-invasive tests, and this is again from the early 2000s onwards, and this messy table is from the EASL guidelines, the European guidelines on non-invasive testing. I just wanted to highlight 3 out of here. So APRI, which is the AST to platelet ratio index, FIB4, which we'll talk about, and the NAFL fibrosis score. All of these, they have, I wanted to highlight them because they have different cutoffs for different stages. So if you're looking for greater than F2 fibrosis or F4 or cirrhosis, they have different cutoff values. And secondly, these are the ones that are free and easy to calculate using everyday lab parameters. If you look at the proprietary markers, so FibroTest, which we can't get in Australia, but HepaScore and ELF are the 2 that we can get in Australia at a cost to the patient, unfortunately. Their performance is fairly similar, but they do have a slight edge over the non-proprietary tests. The shortfalling of all non-invasive tests, whether it be FibroScan or elastography methods we'll talk about in a moment, or the serum methods, is that they rule out cirrhosis very well. So again, F0, F1, and they rule in cirrhosis very well, but in the middle, they don't. So this study looked at the misclassification rate at centrally reported biopsies, and then how well these scores performed. You can see at F2 stage, they all had up to 50%, or between 30 and 50% of misclassification. So we really use these tests, firstly, for the cutoffs they're optimized for. So that might be F3 for fatty liver disease, or F4 in the setting of hepatitis C, for example. And we don't really extrapolate them to earlier stages of fibrosis. The other major test, and probably the most widely validated and used test, is FibroScan, which is known as transient elastography. And what that actually involves is a probe that looks like this, placed against the skin in the intercostal space here, with a mechanical device here that actually places a mechanical pulse and induces a shear wave through the liver that's measured by a one-dimensional ultrasound wave. And so this is what we see when we perform FibroScan in the clinic. We get a graphical representation, and this is the computer drawing a line of best fit of that shear wave traveling. And this is just a 1D ultrasound of what's ahead of the probe, essentially, and you're looking for, that's quite fatty there. But you might see a vessel or a bile duct as a dark spot, and so you know what your FibroScanning is not representative. And so what you're actually looking at is this region of interest, which is represented vertically here. And ultimately you get a median stiffness, or how firm the liver is, the higher being more correlated with cirrhosis. So we're not actually measuring fibrosis itself, but we're measuring liver stiffness. CAP or CAP is this blue number here, and again that measures steatosis rather than any fibrosis there. And then we have our metrics of how accurate or how good we think the measurements were. And the advantage of FibroScan is that single manufacturer. It was very easy to use when it first came about. In fact, it was developed for the food industry in France. It was initially developed to see when camembert were ripe without having to cut into it. So the cheesemongers thankfully allowed their technology to be modified for the liver, and subsequently the validation studies were very rapid in amongst all the developments in hepatitis C around that time. What has emerged in the meantime are other technologies. So and these are actually integrated into normal ultrasound machines. So what we call V-mode ultrasound machines. So this is pulse shear wave elastography, also known as APRI. And there's a couple of major manufacturers, so Siemens and Philips, both manufacture this technology. And instead of a mechanical pulse, an acoustic wave is fired in, and you have a slightly smaller region of interest, but it doesn't give you any quality metrics. This is or 2D shear wave elastography, I should say, is perhaps where things are headed. But again, it's made by at least 3 to 4 manufacturers, all with their own way of instilling this technology in ultrasound machines. So GE, iExplorer, Toshiba, Hitachi all make shear wave elastography. And essentially, this uses a higher frame rate than the one above and measures multiple shear waves at the same time. It gives this real-time color mapping box that tells you that what you're measuring is actually representative of the liver around. But again, there's no quality metrics and there's no standardization. And again, from etiology to etiology, things don't change. So, and you might notice that you're getting reports of shear wave elastography measurements, even though you may or may not have asked for one from various ultrasound providers, but they don't have the same validation as FibroScan. So even with the shear waves, we'll often repeat them repeat a FibroScan in the clinic when you refer a patient. The things that affect liver stiffness, so certainly cardiac failure and congestion in the liver, infiltrative conditions can all elevate liver stiffness, as can recent ingestion of alcohol. A recent meal within 2 hours can also increase your liver stiffness out of proportion. And so often if we see acute changes within 6 months, it's rare for that to actually be fibrosis driven, and more so one of these other factors. What I wanted to hammer across again is regarding F3 fibrosis and NAFLD using FIB4 and NAFL fibrosis score. Both these modalities have excellent specificity and not much sensitivity. So their false positive rate is quite low, translating to a high negative predictive value. So they're really good tests to exclude cirrhosis from a screening population level. And compared to the more expensive scores like ELF and HEPA score, they perform equally in that context. I just wanted to again highlight how straightforward these are. So FIB4, this is from the MDCalc website. You just chuck in your age, AST, platelet count, ALT, and it will give you a score and then tell you what it is. You can also use other calculators online, but MDCalc is well validated. And for the NAFL fibrosis score, again, it does use more parameters. So you need to know the BMI, if they've got diabetes or not, and their albumin. And that will also give you a cutoff. Now, both of these scores use this kind of dual cutoff system, which I'll talk about. So one that's optimized to rule out or to classify into a low risk group, and one to classify into a high risk group for advanced fibrosis. Excuse me. So really the ultimate goal of all these algorithms are to stratify or triage referrals to secondary care. So of this projected 8 million or 7 million patients in Australia with fatty liver disease, how many do actually need follow-up from a liver point of view? And these tests are the things that at this stage are probably the best stratification tools in primary care. So by using either FIB4 or NAFL fibrosis score, you can put them in a low risk category and they can be managed in primary care, because really if you have a low risk of fibrosis, the things that determine outcome are really, the causes of death in patients with fatty liver disease are cardiovascular, malignancy, and then liver disease afterwards. Alternatively, if they're classified into high risk, they should be referred to secondary care or to the liver clinic. If they're indeterminate, now, and this isn't intermediate, it's actually indeterminate. So with those two cutoffs, they're either well stratified to low risk or moderately stratified to high risk. But those who fall in between those cutoffs, we don't know where they are. So they're the ones that go on to need another test. So either FibroScan or ELF or HepaScore. And I guess in the Australian context, none of these tests are really actively available in the clinic, although David, the third speaker, David Baker, tonight will talk about the Liver Toolkit project, which aims to bring some of these tests to the point of care. Again, going back to the British Society of Gastroenterology algorithm that I'd put up before. So this is actually what they've got in their guideline. They've actually specified the cutoff. So if you're low risk advanced fibrosis, they say, well, you should reassess again with FIB4 and NAFLD fibrosis score every 2 to 5 years. And if you're high risk, the same thing. And this has been validated in a real population. This is a London primary care trust catchment of the Royal Free Hospital in Hampstead. And 48% of patients with suspected NAFLD participated, and they got 1,400 of the patients of their catchment. And essentially, they were able to stratify 81% of people who would have otherwise been referred as low risk, and 19% as high risk. Essentially, if you just look at FIB4, how many patients were classified in this first step, 86% were actually classified at low risk of those who were low risk overall. And that coincided with a 5-fold increase in detection of advanced fibrosis and an 81% reduction in unnecessary referral. So a very simple intervention that's resulted in significant implications for that interface between primary care and secondary care. Just briefly in the last few minutes, so general management principles across liver diseases. So with MAFLD, there still is no specific pharmacotherapy, so the focus is still on weight loss and management of metabolic risks, which obviously is very well done in the primary care setting. With viral hepatitis, again, I just wanted to mention it to ensure that everyone's still thinking about viral hepatitis. That should be treated, very easily treated. Consider cofactors for liver disease. So once you have treated them, are they still at risk of alcohol-related liver disease or fatty liver disease again? And don't forget to screen for fibrosis, cirrhosis, and liver cancer as required. So with alcohol, it's really aiming for abstinence in those who are high risk and being firm about that rather than saying that 1 or 2 drinks is okay. It's a very slippery slope. And then finally, with cirrhosis and HCC, it's now moved to a multidisciplinary care model, and we have clinical nurse consultants, dietitians have an ever-increasing focus here, and of course, hepatologists. When and how to refer, you should really consult the Health Pathways website. It's something that we review quite regularly at RPA. I've been involved in the last 3 years since being there in reviewing some of these documents, and they're quite informative and certainly up to date with contact details. I guess the one thing that hasn't been updated is the fatty liver algorithm in our Sydney Local Health District Health Pathways, and we'd recommended NAFLD fibrosis score, but again, you could use either or, with FIB4 being perhaps easier to use. And clearly we can see these patients in liver clinic, but there's also a dedicated diabetes liver clinic for those who have type 2 diabetes run with the endocrinology department. Viral hepatitis, we call more and more upon our viral hepatitis CNCs who have done an amazing job in our network as far as finding patients and getting them on treatment. Certainly, if you have other liver diseases that don't fall into the big 3 of alcohol, viral hepatitis, and fatty liver disease, and send them to the liver clinic. We also have an advanced liver disease CNC, and the role of advanced liver disease nurse consultants is really integral, and Janice will talk about that next. And then finally, if they're HCC or transplant patients, they can also come to liver clinic at RPA. As mentioned before, emergency referrals, certainly anyone who's suspected to have acute liver failure or fulminant liver failure. And I think new decompensation events should warrant an emergency department. So it's the first time the patient's had an encephalopathy or ascites that needs a drainage, or if they're having a variosteal bleed, they certainly need to come to ED. and urgent, new HCCs, new diagnoses of cirrhosis should be seen urgently, and of course the persistent or hepatitis of unknown cause. So to recap the learning outcomes, I think we've been through the majority of these, and the other two speakers to follow on will add. I just wanted to quickly summarise. So firstly, that chronic liver diseases are a top 10 cause of death in Australia and top 5 in certain age groups. The burden and mortality are both increasing at present. The primary care setting is crucial to better outcomes in this group. So I really wanted to hammer home the point that you should have a degree of suspicion for liver disease and instigate screening when you think it's appropriate. There are non-invasive tests of fibrosis have certainly revolutionised and changed the landscape in hepatology. They're readily available and easy to use, either through a liver clinic service or through things like the online calculators. And then finally, that multidisciplinary care is often required for the complex patients and is accessible within this primary health network. And then, well, of course, you can always call your friendly liver unit. We're always happy to answer, give advice, or even decide or help you with the decision on whether to refer or not. I thought I'd just quickly run through some helpful resources as well. This will all be sent out to you. So this is the link for the abnormal liver test guideline that I mentioned. And again, it's a cumbersome document, but it is worth a read at least once. There's been a lot of new Australian-specific guidelines. This one's hot off the press, the new hepatocellular carcinoma Australasian consensus guideline that's been chaired by the GE Society of Australia. The Hep C guidelines were designed in a similar fashion, and they're constantly updated at this website. Hepatitis B guidelines, a new consensus statement similar to HCC and Hep C is due in early 2021. If you're unaware of this website, Liver Tox, this is a comprehensive, peer-reviewed, regularly updated resource that's funded by the NIH in America on drug-induced liver injury. So if you're unsure of a drug interaction or a drug effect on the liver, you can look it up on Liver Tox, and it gives you very comprehensive information, even case studies with the literature summarised. And then finally, both Sally Spruce, who is our advanced liver disease clinical nurse consultant, and myself have been involved in developing the specific therapeutic guidelines for liver disorders, and that's due for release in December this year. And this is again some links to some easy to use calculators for those simple scores that I've mentioned. So I think we'll open up to questions, and if we don't have time to go through your question, you can always email me on that website.
Great, thank you so much, Dr. Majumdar. That was a really fascinating presentation. I'm definitely going to use the fact about fibroscans being used on Camembert as a trivia question at some point. I do have a couple of questions that have come through for you. We have some time to go over them. So the first question, this question, I'm not sure who it came from, but it was sent in prior to the webinar, so thank you for that. The question is, what is the final diagnosis for your patient with minor derangement, transaminosis, apologies for the word pronunciation, and the U-sound and specialist screens are all normal? Do I recall a specialist calling it FAH or similar? And then in brackets, non-fatty liver.
FAH, I'm not sure what that means, but no, certainly there are some patients who have persistently abnormal liver biochemistry, and we don't get to the bottom. I guess one of the things that has changed in the non-invasive era is that we'll often use a test like FibroScan to triage whether we should go ahead and do a liver biopsy. If the FibroScan's abnormal and we've excluded every other cause of liver disease, then I think it'd be hard pressed to do a biopsy unless it was a young patient with a persistent diagnosis that you're still unsure. And often, it might be, often it's medication induced, or it might be something that's not prescription, or that they're inadvertently taking, that might be contributory. The key is that these patients often need, or still will need, ongoing follow-up, and I think that's the difficulty. I think to have a lean patient, so someone with a normal BMI and no fatty liver disease risk factors, no steatosis on ultrasound, I think it's very hard to label that fatty liver disease, and I don't think I would in that setting. Whether you need to clinch down a diagnosis in someone who's got a normal FibroScan, and by normal I mean less than 7 kilopascal, what you're saying is that even if they've had abnormal liver tests for 10 years, that hasn't increased their liver stiffness over that period, and they're very unlikely to have a fibrogenic process. So whatever the reason for their raised transaminases, it may not result in long-term liver issues, but I guess you can only make that call over time. And a FibroScan is something that's very helpful in that setting, but ultimately, personally, I don't like to leave the stone uncovered. So often we end up sending the patient for a liver biopsy, and again, the liver biopsy may show nothing, and you're back in the same same boat. So whether there's something that's evolving over time that's yet to have physiological consequences, it's a difficult thing to say, but they do need ongoing follow-up, I would have thought, in a liver clinic.
Great, thank you so much for that. I also have 2 more questions that have come through from Dr. Kylie Partlin. She has asked, would you suggest referral for a patient with persistent mildly elevated transaminases, say AST and ALT in the 40s, a normal ultrasound and normal liver screen bloods? Should we refer, and what would you likely do if we did refer? And she also asked if GPs can refer for FibroScans, and should we be sending fatty liver patients for these?
So the first question, I think I've covered a lot of it in the last answer. So yes, I think they should still be assessed just to make sure that everything is being ruled out, and at least for longer term follow-up. I mean, often I have a few of these patients that, particularly if they're young, that I see once a year, and just make sure that they're not progressive. As far as the normal ultrasound, mildly abnormal LFTs. The second thing is about fatty. Oh, sorry. The second question was, can GPs refer directly for FibroScan? That's something that we're still working on at APRI, mostly because we do have a technician who helps out during the week, but usually the hepatologist or the fellows, the registrars, whoever seeing that the patient will do it at the same time. So we've only got a limited number of sessions for the FibroScan technician, so we're not yet doing that open access, but certainly you can refer them, and we can consult and do the FibroScan at the same time. Some of those other modalities that I mentioned before, so the 2D shear wave elastography, there's some centres that are doing that, for example, and again, you just have to make sure it's a reputable place. So, for example, I occasionally do send patients over to Alfred Imaging because I know the operators, and I know they report their 2D shear wave results in a fashion that is consistent. And so you can access those technologies, but again, it's the interpretation of what they mean. And again, that's why a liver clinic might be a better option. The third thing is fatty liver disease, and again, yes, you should refer these patients, but I'd use the FIB4 or NAFL fibrosis score triage system that I'd mentioned. So if they're indeterminate risk or high risk patients as by NAFL fibrosis score, then they should be referred on.
Great, thanks again for that. I have 2 more questions for you. Just keeping in mind we moving on to the next presentation shortly. But so the next question was GG persistent raised but less than 100. All other LFTs are normal, and all liver screening tests are normal. What's next?
So again, there's really no single pathological diseases that are associated with isolated GGT. So it's not pathognomonic or anything. As long as you've excluded other forms of liver disease, particularly other forms of cholestatic liver disease, the common things are, as everyone's aware, enzyme induction from alcohol or medications that will give you an isolated GGT rise. Sometimes you might find it in patients with heart failure, for example, but usually, again, you will see an increased ALP, and it would be very uncommon, for example, something like PSC presenting just with an isolated GGT rise. So they're patients that we're happy not to see, and that's why it doesn't feature in the BSG algorithm that I'd put up at the very start.
Okay, thank you for that. And just the final question, for those patients with abnormal LFT but a normal scan, at what stage of raised transaminases, sorry, that word always gets me, would you refer for a fibroscan? 2 to 3 ULN?
Yeah, I think that's pretty, yes, yeah, 2 to 3 upper limit of normal is reasonable. I think the trajectory is also, so if it's a one-off, I guess you'd repeat it if it's only 2 to 3 within 2 to 3 the upper limit of normal. But if it's been persistent for 3 months, then yes, that would be enough to refer on, and you've excluded other causes.
Our now second was third speaker, Dr. David Baker, will be presenting on the Liver Toolkit project. And David is a GP and director at the eSydney Doctors in Darlinghurst, where he's worked for over 20 years. He has a special interest in a number of things, including hepatitis, and he's also one of our GP consultants for the Liver Toolkit project. So I will hand over to you now, David, and I'll keep note of any questions that come through for you.
Great, thanks very much, Zoe, for the invitation, and thanks, Avik, for a fantastic presentation on liver disease and general practice. And I learned a great deal from your talk. And so moving on now, we're going to talk for the next few minutes about a project called the Liver Toolkit project. And I think this is bringing together a lot of these new ideas into a tool that potentially can be very, very helpful in primary care. So Avik did a great presentation on what are the common liver diseases in general practice, and also the complications of liver disease, which are increasing. And I think he highlighted very well some of the difficulties of diagnosing cirrhosis in general practice. And also, there's some uncertainty about the uptake of recommended monitoring of people with known cirrhosis. So this project is looking at a lot of these issues in primary care. And this again is just my pop view of liver disease with the big four: viral hepatitis B and C, alcohol, and NAFL. And then in some people leading on to cirrhosis. I mean, some people will still, of course, can go to cirrhosis without can get hepatocellular carcinoma without developing cirrhosis. That's particularly hepatitis B. But in general, most people will develop cirrhosis before they develop the complications. And I mean, this project is really looking at people with known cirrhosis, but also in people who have at risk of having cirrhosis and diagnosing them, and also the management of people who have been diagnosed with cirrhosis. Are they having the essential follow-up, particularly 6-monthly ultrasounds? And again, this is from a paper that Avik mentioned, and I think this was, it's quite sobering that liver cancer is the one cancer that has a markedly increasing incidence compared with most other cancers. And this really is related to the big four that Avik has discussed earlier, which also are the main leading causes of liver transplantation. So now looking at the Liver Toolkit project, the background is it was funded by the Cancer Institute of New South Wales, and it's a partnership between our local primary health network, Royal Prince Alfred Hospital, and St George Hospital. To summarise the project briefly, it's really designed to identify patients in general practice with or at risk of cirrhosis, to try and make sure they have appropriate surveillance and, if necessary, connection to a local liver clinic. And also to encourage the use of technology such as HealthLink to improve communication between GPs and hospitals. The main outcome, this is from the the project synopsis was to improve management of cirrhosis in general practice, particularly detection, and a shared care model between general practice and specialist centres. And also a secondary objective to establish clinical support pathways for primary care providers who have patients with liver disease. And that's also introducing some of the non-invasive markers that Avid mentioned. So looking at how the project works, male and females, adults are eligible for the project. So this will include patients who are diagnosed by GPs with cirrhosis. We'll have risk factors for cirrhosis according to a tool that we'll discuss in more detail, something called POLAR, which is a web-based tool that can examine your practice database. And of course, a small group of people who actually have a history of HCC. So patients diagnosed with cirrhosis or at risk are identified in the participating GP clinics using, with the support of an online tool called POLAR, which is part of the Liver Toolkit. And then eligible patients are then invited to participate in the study and would in some cases be either investigated at the clinic or referred to a specialist centre. So this study will run for about 30 months and will follow patients' management and the establishment of clinical support during that period. And there'll be regular visits to the clinic about every 3 months by someone called a clinical health liaison, which is a nurse specialist or probably a liver registrar. They will then look at the results from the Liver Toolkit and export data to a secure website on site. And they'll also review patient history to identify people with cirrhosis or cirrhosis risk and look at the need for treatment or referral. So currently there are 8 GP clinics that have signed up for the study, and there are probably a couple more practices that could be recruited, and that would be something we will discuss a little bit later to try and get the numbers up to perhaps 10 or 12 clinics. Probably most people watching have used search tools within their software, and they work, but they have pretty basic functionality. Last year, I was involved in the early rollout of a POLAR tool, which is really quite incredible how quickly and how well it examines your practice database. So I'm just going to show some data from our own site. So this is it's an online web-based tool that it doesn't reside on your own desktop. You have a password, and this tool will examine your practice database. And so on our site with 42,000 patient files, in this case, it was looking for hepatitis C and pulling up about 2,000 records. So it's very good at very quickly looking at your practice database and pulling up results. And this was at the time, I thought the most phenomenal example of how powerful these web tools are. The POLAR tool looked at all the current patients, as a patient who's presented in the last 2 years, and calculated all of their APRI scores. As Avik mentioned, this is a very useful, very quick tool that can indicate either high risk of cirrhosis or patient at low risk of cirrhosis. And this is something that probably many of the people on this webinar will have used to assess patients with hepatitis C, for example. And certainly now, many GPs have treated hepatitis C in primary care, and the current data says over 6,000 GPs have actually written a prescription for hepatitis C treatment, which is pretty remarkable. But the widespread use of the APRI score has really been very helpful in that it's allowed GPs to assess someone with hepatitis C, and if they have an APRI score of less than 1, to be pretty happy that the patient's unlikely to have advanced liver disease and could then be treated with antiviral DAA therapy for hepatitis C. So, but I thought it was quite phenomenal that just in a couple of seconds, this tool could examine, you know, the 10,000 current patients and calculate the APRI scores. So we can see that in the histogram that most patients really have quite a low APRI score, and there's a long tail of people that have quite high APRI scores. So these are the sort of patients that would be pulled out in the study to be examined in more detail as to their likelihood of having cirrhosis and needing a specialist review. So if we carry on past there's a number of, in the reporting function of POLAR, you can click on a variety of tabs, again looking at the major conditions. So this does a quick summary of people who have cirrhosis. So in this case, 98 patients were identified as having cirrhosis. And then we can see some good things and not so good things in terms of the reporting, that a large percentage had had alcohol intake recorded, but a tiny number had had an ultrasound in the last 12 months, only 3%. This is, of course, where some limitations of these type of programs emerge, because looking at your database and pulling up all the ultrasound results is something the tool can't really do completely, because a lot of these results are recorded as just scanned documents and so on. So these patients would have to be the records would have to be manually examined, because to find out what the true number of patients are that have had these preventative activities performed. In terms of looking at what are called atomized results, these are results from the path lab that are stored as numbers. These tools are really excellent. So again, that's the tab to do with cirrhosis, which is a major part of the Toolkit project. Now moving on to NAFL-MAFL, this had two tabs, one for under 65 and one for over 65, because they have slightly different criteria for identifying these populations in under or over 65. Again, 172 patients were identified basically from the problem list, and fortunately, a good thing that the vast over 90% had had their weight recorded in the last 12 months, so that's a good thing. But in terms of other investigations, far fewer had had these done. As I've mentioned, the FIB4 calculator, that can all be calculated automatically by the tool, and that can be used to find patients who are at higher risk of cirrhosis, and then they can be individually check their files. Hepatitis B, again, is in our area, our primary health area, has a very high number of people living with hepatitis B, and in our population of active patients, there were 123 recorded as having chronic hepatitis B, and unfortunately, only about 60% had had a liver function test in the previous year, but a tiny number had had an ultrasound recorded. So this, of course, represents, according to the report, a great failure in primary care. Again, one of the problems is, then if we look down at how many people with hepatitis B had had their DNA levels recorded, again, it's a tiny number. And the problem here is that, again, the software has some limitations with looking at serology, which really became apparent looking at hepatitis B and C. Looking at the Hep C tab, within the current population, again, there's another couple of major issues. One is 500 patients were recorded as having hepatitis C diagnoses, but the major problem here is that according to the software, none of these patients had had a PCR RNA checked, which is extremely unlikely. So the problem again is the software is struggling to read serology path reports, similarly with the ultrasound as we discussed. So there's more development work to be done with the tool, but it's certainly very good at identifying patients who may need further examination. So alcohol use, abuse, dependency, there's a couple of ways of looking at that. It's from assay looking at the active population and how many people have alcohol dependency or abuse recorded, and that pulled out 155 males. And also you can look at the data in terms of how many males who have having more than 50 units a week, if that's been recorded. So it looks like 65% of patients had their alcohol intake recorded in the medical record, as in days per week and units per day. So that's another area where the software can be very helpful at finding patients. And moving on to the final tab, with all of these tabs, you can drill down and actually see the patients. For this, of course, we're not doing that, but under the management tab, we can see down the bottom a histogram of some of the common groups of patients that the software has identified. So males and females with heavy alcohol use, history of alcohol abuse recorded in the file. Again, there's two ways of looking at alcohol. People who could have fatty liver disease and so on. So in all of these, you can click on tabs and you actually see the actual patient data and you can examine that in detail. So just to summarize where we're up to with the Liver Toolkit, this project is just at the beginning. So some of the GP sites are starting to have visits from the liver team, but potentially this has multiple benefits in primary care. I think ultimately to improve patient care, it's going to generate some very useful research findings, because really in Australia we don't have really good population level data about the prevalence of cirrhosis. So this potentially could provide some very useful findings in that respect. It's also a very good quality assurance activity, and also can introduce very useful technology into general practice. So thank you very much for attending this session. If you're interested in participating in this project, please provide your details in the chat box, or you can contact Jane Miller at the PHN. Great, thank you.
So as we know, liver health can be impacted by the use of drugs and alcohol, and in the Sespen region there is a GP liaison in alcohol and other drugs project. So this project aims to assist drug and alcohol services to work collaboratively with you and your general practice, and the GLAD drug and alcohol nurse can provide you and your patients with assistance through phone advice, practice visits, assessment and treatment plans, as well as collaborative shared care. And this is a collaboration between other alcohol and other drug services and our 3 local health districts within the Sespen region, so including South East Sydney and St Vincent's Health Network. how do I get information, or how do you get information about this? So these slides will be sent out with the presenter's slides as well. So you'll be able to come back and click on the hyperlinks and take a look at these phone numbers. So this information is also available on our website, and there is with information for each of the 3 networks. And finally, just wanted to promote the National GP Education Package for drug and alcohol treatment. So if you're interested in furthering your education regarding alcohol and other drugs, there is an opportunity for you to engage in the National AOD Education Package. And again, if you would like more information, you can either go through our website, or you can contact Esther Toomey, who is our Drug Health Promotion Officer here at CESPN.
Should we be doing APRI score in patients with abnormal liver function tests on a regular basis?
Well, I think it's a very, I think if we just go through the pathways that AVIC has discussed, and I think doing an APRI score is very quick and easy, and that provides us a degree of reassurance about the likelihood of advanced liver disease. So if you just type APRI into Google, it will take you straight to the calculator, and then you just put in the numbers and you get a result. And if it's less than 1, then as Avik mentioned, these tools are good at showing early liver disease or the likelihood of cirrhosis. So if you have a nice low score and you've done all your other basic tests, and that's quite a useful thing to do, I think.
Okay, thank you very much for inviting me to speak tonight. I just want to speak about a great collaboration I feel that some of our nurses have had with GPs over the years. Next slide, please. And look, we're very keen to move forward and try and develop a mutual partnership and even build it stronger to what we've had. And the nurses are very keen to work with GPs, as are the hepatologists. And there's a great deal of international consensus on this as the burden of liver disease is growing internationally. And recently, the UK Liver Trust put out a petition to try and increase the number of resources, especially for GPs, to help manage liver disease. And we, as clinicians at the hospital, the hepatologists, we really need to try and understand a little bit about what your needs are. So we're very willing to take any questions, any phone calls, and offer as much support as we can. And a growing amount of hepatology nurses are working right across Australia, really, at trying to build new models of care and to decrease the risk of liver disease progression, and also to just try and keep patients out of hospital. Next slide, please. So the types of models of care that nurses are doing to look after patients in the community and to work with GPs is really trying to help identify people with hepatitis. And so in our local health district, we're following up notifications of hepatitis B and hepatitis C. And so therefore you may receive a phone call or a fax from one of our nurses. And we can help you try and either link that person to care, give you any advice or assistance you may need. And it's now appears like we're coming to the third wave of treating hepatitis C. And we've seen a large number of people who need to get treated, but they've got really complex psychosocial issues. Perhaps there's a lot of ICUs going on. And we're really trying to build bridges with these people and trying to link them with services. We also have a nurse practitioner who, if you're having difficulties trying to engage with a client, trying to get them onto hepatitis C treatment, our nurse practitioner may be able to help you out. And the contact details are in the health pathway. And in the past, we have done some nurse outreach where we've had our nurses go out and do some fibre scan visits to GP practices where they have a high burden of hepatitis B or hepatitis C. And the nurses gone perhaps once every 2 months or so to conduct a fibre scan, and that has worked really well. And with COVID, community transmission of COVID decreased, we had to start that up again too. Next slide, please. And now our latest model is what Avik was talking about. We now have a nurse who's really trying to help support people with advanced liver disease and cirrhosis, and using more into an integrated care model. And she may quite often meet the patients when they're being admitted in hospital, and they're quite often chaotic and need quite a bit of organisation and help to try and stay well in the community and have someone to look after them, coordinate their care so they can stay out of hospital and not come in as an emergency admission. We have an increasing number of transplant nurses, but what we're really seeing is a lot more nurses doing HTC, so liver cancer case management. And at Prince Alfred now we have 3 nurses doing that, and it's really overtaken from a lot of that old hepatitis C work that nurses were doing, looking after patients on interferon-based therapy. We also have nurses doing a lot of clinical trials, and so it's another reason why to contact nurses and find out what's going on, because we have clinical trials for NASH, a lot of liver cancer trials, we have new hepatitis B trials. There's a lot going on in that space. Next slide, please. So we can offer, the nurses can offer, you know, phone, email support, health pathways. We've had a long history of being involved in the development of those health pathways. And as I said, the nurses are involved in the liver toolkit as well. And we're moving now towards e-referrals. So we're hoping to see a lot more e-referrals coming in after October this year. Thank you. And now my contact details are there on the slide. So very happy to take calls. I quite often do get calls, and very, very happy to take them. So I'm always hoping I can help a GP out. Thanks very much.
What blood test would you include as part of a liver screen for abnormal LFTs?
Well, I think you go through your list of viral hepatitis. So hepatitis C antibody, the 3 hepatitis B serology tests, antigen antibody and core antibody, and then you'd want to sort of rule out hemochromatosis, and I would generally do ferritin or iron studies, and you probably would have done a full blood count. I guess you're looking for markers of alcohol use, and then you go down those pathways that Avik mentioned, and you do different tests at different times. You may want to do an ultrasound, and of course take a very thorough history, because a lot of the, especially about medication use, and that includes over-the-counter and recreational drug use. So that's probably, off the top of my head, the main things you do. You might do coagulation screen. So you'd often start with some basic things and then work through to more exotic causes. And it would also depend on how unwell the patient is. If the patient's very unwell, you'd be referring them off quickly. If they're not unwell, you'd be doing things in a more leisurely fashion.
So can I add in something to that?
Janice?
Yes, just the platelets are really, really important. So if you're suspecting cirrhosis, just look at the trend of platelets, and if you see the trend of platelets going down, then you would start to get worried. So platelets is really a key marker. And if you look at a lot of those algorithms and tools that are using, a lot of them include platelets, because that is really a key indicator.
Yeah, I think that's a really
full blood count.
Yeah.
Yeah.
So and then I think the earlier person asked about doing an APRI score. I mean, that's a good way of looking at the likelihood of advanced liver disease.
Yes, that's right. Yeah.
Is Zabak on the line? Does he have any
sorry.
points
That was great, David. Sorry. Only thing I'll also add would be what we've found in the recent literature is that alpha-1 antitrypsin disease is a lot more common than we thought, and it does provide a cofactor, and in fact it's just having one abnormal allele of alpha-1, so what's called a Z allele, is a more predictive has more predictive ability for advanced liver disease than the few genotype or genetic polymorphisms that have been identified for alcoholic liver disease and fatty liver. So it is something that's worthwhile screening for because it's a genetic condition, and it's a very easy test to do. So if they're low in alpha-1 antitrypsin, then that would really influence how quickly they may develop liver disease. So unless they've got florid alpha-1, so 2 Z alleles and florid alpha-1 antitrypsin disease, doesn't really cause cirrhosis by itself, but it will certainly accelerate fatty liver disease or alcohol-related disease or any other form of liver disease. So it's definitely worthwhile throwing in the general liver screen. As far as autoimmune screens, I completely agree that it's something that you should probably hold off. I wouldn't do one on everyone, and certainly the population we see in liver clinic has already been stratified and seen by general practitioners. So although we send off the shotgun approach liver screen, and again, most of the tests are already done, and we're often looking for a change, I wouldn't jump to autoimmune markers as a first-line test. The other quick point I wanted to make was about APRI, and APRI has excellent validation in hepatitis C. You can, as David has mentioned, you use APRI or to determine your treatment, whether the patient's cirrhotic or not, although that's going to change very shortly. It won't matter if they're cirrhotic or not. But there's some recent data presented at the online European conference, again, doing similar things to the Liver Toolkit project. And they found that platelet count, this is using a Welsh cohort, so they basically had 500,000 primary care participants in a whole Welsh suburb, but province, and they just used AST to ALT ratio to screen, because they found that in general practice, the reduction in platelet count, if you're not looking at other factors, so clearly we have clinical assessment as a major driver, that the causes of thrombocytopenia were often other than liver disease, if you're not looking at the bigger picture. But I guess it's very different when you're talking about a patient interaction where you know what you're thinking at the moment. But I think APRIs are easy to do. They give you some reassurance, as David has said. But I think in the end, if the patient has persistently abnormal liver tests and you're worried, then just refer them, and we're happy to see them.
Yeah.